Like many ailments, an abdominal aortic aneurysm often has no symptoms, and when you do feel something, it could be too late, making it a silent killer. What is it? Who's at risk? And how can you detect and treat it? Cardiothoracic and vascular surgeon Dr. John W. Davis with Davis Vein and Vascular Center has the answers. Good morning, Dr. Davis.
Hi, Deborah. How are you?
Good. All right. I had a brain aneurysm that actually burst, but explain what an abdominal aortic aneurysm is.
Well, the abdominal aortic aneurysm, or I'll call it AAA for short, is a weakness in the wall of the aorta, typically in the infrarenal location or below the kidneys. You can see the diagram there. But basically, it results in a 1.5 times greater diameter than the normal aorta. And so as that aorta gets larger, the wall can get thinner and the risk of rupture goes up. And as you've discussed, there's several famous people in our country that have died from the silent killer, as you said.
Yeah, it usually affects older Americans, but John Ritter was only 54.
Right. The risk factors and causes are kind of lumped together, but basically Caucasian males in their 65 to 75 year range that smoke are at highest risk. Other ethnicities are not as high at risk, but certainly still are at risk as well. And females don't have as much incidence of this. Males over females are about 2 to 1 in general.
Yeah. Family history.
I would also say that family history is important. Those family members, first-degree relatives that have aneurysms are 15 times likely to have, or more likely to have aneurysms themselves than the normal population. So those people that know that their families have aneurysms need to tell their doctors and need to get screened for this problem.
Yeah, and as we mentioned several times, when you have diabetes, cholesterol issues, that all can add to it as well. How is it diagnosed?
Usually starting with an ultrasound or a CAT scan. An ultrasound is non-invasive, it's easy to do, it's inexpensive, so it can be done at the hospital or in the office with a minimal amount of time and equipment. That gives us some screening information regarding the diameter of the blood vessel, the aorta in this case. And typically, if we're finding some aneurysm there, we would go ahead and follow that up with the CAT scan, which gives us a lot more information about the size and dimension and other vessels in location in preparation for a surgical intervention if that's appropriate for the patient.
Yeah, and let's speak to how important this is to get to before something bursts. I know with my brain aneurysm that burst, it put me in a whole different category of survival. If they had seen it before, I would have been much more comfortable going into surgery.
Absolutely. So we know that aneurysms that are 5 centimeters or greater in males and even 4.5 centimeters in females are criteria for repair, even if they're not having any symptoms at all. Also, another red flag would be an aneurysm that's growing 0.5 centimeter in a 6-month period of time is also worse prognosis for failure. So those things are important to know as well.
Yeah, so you have surgical correction. The open endovascular aneurysm repair is one thing you can do.
Yeah, the treatment is surgical treatment is usually twofold, or 2 different types. Surgical open traditional treatment has been done for the last several generations. I shouldn't say generations, but decades. Open repair is more invasive. Surgery is longer. It involves more blood loss and more recovery time. Patients typically stay in the hospital 5 to 10 days on average. So it's a significant amount of recovery. It is very effective, but it's on the scale much more invasive than an endovascular approach, which is new technology over the last 15 years. I'm going to use a model here, so bear with me. But the endovascular repair has been around for the last 10 or 15 years, and it's much less invasive. It's a minimally invasive approach. It is done in the hospital. But basically, if this is a tearaway model of what we're talking about, you see the aneurysm of the aorta here, and it's below the kidney arteries. This is an important landmark for placing this device. The kidney arteries, if the kidneys are here on both sides, then you know that this is an infrarenal aneurysm. And so we're going into the groin on each side percutaneously, avoiding a surgery, although sometimes a small surgical incision is required in the groin, but typically not in my practice. And we're placing a device up inside the aorta There's usually two pieces to this, but one is deployed on one side and then a piece on the inside on the other side. And so then you get a seal up here and a seal here and a seal over here, so that as the blood is traveling down the stent, it's not pressurizing the sac, the aneurysm sac. And so over time, that sac involutes or gets smaller and your risk of rupture approaches zero.
Yeah. So
we do these over at Kingwood Medical Center. And I'm happy to say we have a brand new hybrid suite there that I'm very excited to use and be able to provide that to my patients. State-of-the-art technology and equipment and 3D software, so we're able to reconstruct the patient's own aneurysm in real time as we're doing the procedure. So,
and the key is
look
to make
forward
this
to that.
preventative. Absolutely. Dr. Davis, thank you very much.
Thank you.
And if you are at risk for an abdominal aortic aneurysm, meaning you are a smoker, ages 65 to 75 with high blood pressure or have a family history of aneurysms, please talk to your doctor or call Davis Vein and Vascular Center at 936-441-1010. That's 936-441-1010. You can also visit them online at davisvein.com.